Okay. So today we are going to hear from Andrea Thomson and Joanne Winsor on mental health nurses who experience disabilities, barriers, and inclusive practices. Andrea is a registered psychiatric nurse and assistant professor in the Department of Psychiatric Nursing. Her research interests include undergraduate nursing education, professional boundaries, ethics in nursing, and acute care mental health nursing. Andrea is currently building a research program that's focused on the experiences of nurses and psychiatric nurses who experience disabilities. Joanne Winsor Murray has been a registered nurse for 25 years, holding different positions as an educator, manager, and consultant. Currently, she is an assistant professor in the Department of Psychiatric Nursing, and Joanne completes research exploring families' experiences in healthcare with a growing interest in psychiatric nurses and their education experiences. So we welcome you today, and we're excited to hear what you have to tell us in regards to the barriers and inclusive practices around some of these experiences. I'll toss it over to you.
Thanks, Tracy. Thank you
for
the introduction, Tracy. So I appreciate you introducing our project. This is the first time we're actually presenting on this research. And I want to note that the research was not funded and has been accepted for publication in Issues in Mental Health Nursing. And thank you again, Tracy, for completing the land acknowledgement. And we just want to note that we at Brandon University acknowledge and respect the history, land, and people in Turtle Mountains, the ancestral land of the Dakota and Ojibwe. Now I will hand it over to Joanne.
All right, just a few slides here to give you a little bit of background information to help provide some context for the research that was completed. When you think about disability, the physical ones are much more easy to understand and more apparent than others, but some disabilities are not always observable, right? What that also means is that sometimes the impact may not be directly observable either. So to look at it broadly, disability can be defined and experienced in many different ways. So for this study, we use the definition from the Government of Canada legislation. So bear with me as I read this directly because it's a very wordy but all-inclusive quote. It's the physical, mental, intellectual, cognitive, learning, communication, or sensory impairment, or a functional limitation, whether permanent, temporary, or episodic in nature, or evident or not, that in interaction with a barrier hinders a person's full and equal participation in society. So that is from the Government of Canada, and the references at the end. It's also interesting to note that the World Health Organization also includes experiences of stigma and issues with accessibility in their definition. So why were we interested in nurses, other than the fact that we are nurses, and what did the literature tell us when we started to have a look? Nurses with disabilities have a crucial, if not unique, role in healthcare as they bring their lived experiences through the care that they provide, ultimately potentially improving patient care. It's also clear and repeated in the literature that despite the potential valuable contributions, people with disabilities are continue to be underrepresented within all healthcare professions, which includes nurses. And finally, many nurses with disabilities face unique challenges in their professional lives. Some of these notable challenges involve attitudinal barriers, such as the experience of stigma, marginalization, discrimination, and ableism. Ableism, it's an interesting term. It's refers to the enduring disability-related discrimination that is exploitive and often intimidating. So we also looked at the legislation. So there is legislation in place and has been for many years to protect the rights of people with who experience disabilities. And in 2019, Canada adopted the Accessible Canada Act to assist with identifying and removing barriers for people with disabilities. However, workplace accommodations are considered a human right, and that was established back in 1985. And employers have, for a long time now, had the legal obligation to provide reasonable accommodations to people with disabilities. However, the available research has found that accommodations are largely underutilized and often difficult to access, especially in healthcare environments. And despite the legislation, people with disabilities do not experience the same access to work opportunities as those without a disability.
Overall, we found that there was a lack of available research regarding nurses who experience disabilities. In addition, there was no available literature that we could find specific to the experiences of mental health nurses who experience disabilities. We found that these perspectives were important to capture to better understand the unique experiences of those in this nursing specialty. So the aim of this study was to identify factors that promote or limit the inclusion of mental health nurses who experience disabilities related to their professional practice. Interpretive description was selected as a research method to better understand the perspectives and practice experiences of mental health nurses who experience disabilities. Data collection involves semi-structured interviews, and we conducted the interviews remotely using Microsoft Teams or Zoom. So we interviewed 10 mental health nurses who self-identified with experiencing a disability at the time of the interview. Their years of experience ranged from 4 to 35 years as a mental health nurse. 9 participants practiced as a registered psychiatric nurse, and 1 participant was a registered nurse who worked in a mental health setting. All of the participants were employed in a mental health setting at the time of the interview, including 4 in acute care and 4 in community-based care and 2 in long-term care settings. The majority of participants identified as male, followed by female, and 1 participant identified as transgender. We have included details on gender because the experience of gender also seemed to influence some of our findings. The type of disability reported by participants were physical disability with 7 participants. Mental illness was disclosed by 5 participants, and learning disability was disclosed by 2 participants. 3 of the participants disclosed multiple disabilities, such as the experience of a physical disability and a mental illness. 2 participants reported that they experienced disability during their education, but did not receive a formal diagnosis until many years later. So the onset of disability for the majority of the participants took place during practice. So what did we find? So participants discussed challenges associated with the mental health system. They discussed the need to adapt related to barriers associated with care, but also related to coping with the experience of disability. They described the importance of support, resources, and feelings accepted at work. So our themes were workplace barriers, supportive leaders make a difference, mental health nurses with the disabilities adapt, and the need for additional resources and to feel included. And I'm going to talk about each of these themes and sub-themes in more detail. So the first thing, workplace barriers, was divided into a few different sub-themes. So risk of violence and changing employment was discussed. So the risk of encountering violence while at work was noted within mental health care, especially within acute care settings. The risk of violence was not specific to mental health nurses who experience disabilities. They discuss risk for all nurses employed in mental health settings. However, encountering violence in the workplace was described as especially concerning for those who experience disability. So violence was associated with an increased risk of physical injury, but in addition to that, exposure to violence was associated with poor psychological health and safety, and could contribute in some cases to increased symptoms of anxiety and in some cases trauma disorders. Several participants left acute care settings due to the risk of violence that they experienced. 4 participants transitioned from acute care to community-based settings related to this particular risk. 1 participant was accommodated by the workplace and was transferred to the community-based settings, whereas the 3 other participants chose to work in community settings. 1 participant said she was not able to return to an acute care setting because she no longer met the job description of a lifting restriction. Cassandra described the experience of experiencing violence within acute care and then transitioned to community-based care, however, continued to be exposed to violence in community-based care, as demonstrated in the quote that you see on the screen. So additional workplace barriers was in regards to workplace accommodations. Experiences as a mental health nurse and the accommodations provided differed based on the type of setting. Overall, participants reported that community-based settings were more accommodating compared to that of acute or long-term care. It appeared that those who experienced a physical disability were more likely to receive accommodations than those who experienced a mental health or learning disability. However, a lack of accommodations were noted overall. The participants found that even when accommodations were provided, they were often restrictive rather than helpful. So as Jim stated, there are times when working 7 shifts in a row are extremely demanding on my body, but when I met with human resources and management, I'm made to feel that I'm not putting in enough effort or I don't care, which is certainly not the case. There should be some way of dealing with someone who has illnesses, but not to the point where they needed to be off work due to disability. So in Jim's experience, he was required to work 7 shifts in a row related to his EFT. And although he struggled with those long stretches, the employer recommendation was time off work rather than looking at a different rotation. So here's just a list of the types of accommodations that our participants discussed. The table includes that also accommodations that were not provided. So you can see that there were 2 types of disability not provided in acute or long-term care. One was lifting restriction that 2 participants were not able to receive because it conflicted with job description. And 1 participant was not able to use a supportive device. So in this case, it was a crutch. Because it was viewed as potentially being a weapon in a long-term care, in an acute care setting. So participants, we also found that participants who experienced a mental health or learning disorder were less likely to receive an accommodation. You can see that 1 participant did not receive accommodations because of fear of disclosure. And 1 participant did not receive accommodations and they were not aware of any potential accommodations that would be provided to them. So types of accommodations that were provided included no overtime, not being able to work any overtime, taking an extra break as needed, an ergonomic workstation, travel restrictions. So in that case, it was not driving longer than a total of 1 hour per day, flexible hours to attend medical appointments, and in some cases that change in employment or transfer from acute care to community-based care. So continuing to discuss workplace barriers, the experience of stigma and discrimination were reported. Challenges were experienced in the workplace related to stigma and discrimination, which was perpetuated from colleagues and management rather than clients served. Participants reported that disability was often perceived as laziness. Regardless of the type of disability, so physical, mental, or learning, all participants described encountering some level of stigma and discrimination in the workplace. This left them feeling less than, unappreciated, or replaceable. Mira shared a story where she was rubbing her leg to distract from pain, and colleagues labeled this behavior as sexy and joked about it. Mira described this experience as hurtful bullying and had the following advice. If I'm accidentally drawing attention to my thigh, this has nothing to do with feeling sexual, but has everything to do with managing my own inner condition. If you're working in a healthcare field, you're going to be working with vulnerable people. So it's important to be non-judgmental. Seek to understand all behavior has meaning. You're not entitled to know every aspect of everyone's life, so just be gracious. Another major theme found was involved leadership. So a supportive leader makes a difference. Regardless of the type of disability or the workplace setting, a factor that led to success and positive experiences involved supportive leadership. However, not all participants receive this type of support. The differences in experiences are highlighted in the 2 participant quotes. Brent reported he had a supportive manager and was comfortable talking with her and received supports and accommodations needed. Carl, on the other hand, initially had a supportive manager. When a new manager took over, they were not accommodating or supportive, and Carl was left trying to advocate for himself to maintain accommodations that had been previously provided. Mira had a similar experience. The disability, the workplace, and the accommodations did not change. However, her experience changed from positive to negative with new management. An authoritarian approach was found to be unhelpful, whereas a trusting, supportive approach led to success and feeling included. So the next theme was nurses with disabilities adapt. So the participants recognized the need for personal wellness to provide safe, ethical, and competent care. So this was discussed as that fitness to practice. Many participants described periods of time where they were not well and required a medical leave to focus on themselves and their health. Receiving a diagnosis often helped participants develop a treatment plan so they could then return to work safely. They described a process of taking an active role in their recovery so that they could focus on client care and not themselves. As Barry stated, it's a fine line between knowing you have a disability and develop coping mechanisms to adjust and figure out how things best work for you and your life. If someone has a physical disability or a mental disability, they need to take an active role in what's going to help them and not have everybody do everything for them. So taking an active role in terms of their health so that when they were at work, they could focus on client care. Nurses with disabilities adapt, and they talked about the importance of coping strategies like maintaining a daily routine, engaging in mindfulness, yoga. These types of strategies were emphasized as being important by participants. When discussing workplace coping strategies, the need to take a break was commonly reported as being helpful. However, mental health nurses, especially those employed in acute care settings, reported that breaks were often missed due to high patient acuity, which was found to be difficult and could exacerbate symptoms of disability. Participants reported the experience of disability actually helped to improve the care that they provide. So it increased their ability to provide empathetic, compassionate care, and also advocate for those that they serve. Amy reported the experience of disability has improved her ability to provide care through building therapeutic relationships. So Amy said, having a disability doesn't disqualify me from being a good nurse or being a good counselor. Rather, it strengthens the relationship. But I have to practice boundaries and I have to separate my own personal life from work. The final theme is the need for increased resources and inclusion. So all participants described the desire to feel accepted and supported by both leaders and colleagues. They didn't want to be accommodated, they wanted to be included. They enjoy their work. They want to work. They want their strengths recognized. They want to collaborate with leaders to find common ground so that they can provide care. However, as noted previously, they were often met with barriers and spent a lot of time advocating for themselves. The most common type of support offered to those who experience disability was the Employee Assistant Program, EAP, for counseling supports. One participant found this resource was helpful. However, all other participants said it did not meet their needs. Participants stated that resources should be provided within the workplace to promote wellness and build supportive relationships. They talked about formal counseling supports rather than just short-term EAP types of supports. And they talked about the need to debrief with colleagues. So after a critical type of incident, debriefing was found to be really important and helpful in building those positive relationships with colleagues. So now I'll hand it over to Joanne.
So pulling all of this together, there's a lot of details. What we heard was that participants highlighted the importance of feeling accepted and supported by management. In fact, supportive leaders and management was probably the most common factor that led to success and positive experiences regarding their workplace inclusion. Managers that participants reported as trusting and supportive allowed for ease of disclosing the disability and working through changes related to accommodations. They were also much more likely to speak to managers who were willing to be flexible and work with them to achieve shared goals. Some of the available research also reinforced our findings that a supportive and trusting approach from management that leaned towards integrating nurses with disability as opposed to just accommodating them is also associated with decreased experiences of stigma. So given the significance of this result, it became clear that we have identified additional research regarding leadership roles and responsibilities surrounding the accommodation processes, hopefully the next steps that we can start to look at. These nurses also differentiated how there needed to be a time and a place to care for themselves. Some of that was just in their adaptability, but they felt that they could better care for their clients in the workplace, but it needed to be supported by medical leaves and or through the accommodation process, which were not always in line or congruent. This highlights the systemic insufficiencies, a lack of support, the inflexible processes associated with healthcare systems, HR systems, etc. Mental health nurses were also required to adapt with and without support. And while adapting has provided them with a lot of strengths, actually, they continue to face additional hurdles that were really necessary in a lot of respects. So when accommodations were provided, in many cases, they did not meet the actual needs of the mental health nurses. There was a Canadian workplace study that also found the needs of employees with disabilities are going unmet. That's Morris et al. 2019. There was also some open negotiations and revisions of accommodations, given that needs change and some disabilities are actually quite episodic. And a couple of other studies highlighted that piece as well. Some current policies make it challenging for individuals to renegotiate accommodations, and that also was highlighted in the research when we went back and had a look. There are flaws in the accommodation processes and practices, and they're often looked at as a limiting approach, which focuses on deficits. And that was also highlighted in the research that we looked at and in our study as well. I guess what was understood from mental health nurses with disabilities through their experiences with accommodations and the work setting is that nurses are adapting. They have multiple barriers, and the healthcare system is ultimately not meeting their needs, if we could sum it up like that. The role managers and supervisors play in the support of workers with disabilities should be explored within healthcare, as they have such a significant impact on the nurses' experiences, positive and negative. These results have also highlighted some legislative requirements to identify, remove, and prevent barriers to accessibility. They're certainly not being met, and to reduce the need to reduce the marginalization of mental health nurses. the system actually needs to be a lot more flexible than what was described and what we've seen. So this would benefit all nurses and those that are actually cared for as well. The needs of nurses who experience disabilities are largely unmet in our mental health care setting. And while every nurse should be entitled to a break, every nurse should have the choice to go home at the end of a shift or work overtime if by choice. And every nurse should have the ability to use supportive devices if they require an accommodation. These basics are not always available to nurses. By examining the accommodations that are provided and not provided, healthcare leaders can actually begin to see parts of the system in need of addressing. So these areas should be universally addressed so that all nurses working in the settings can have their needs met. This would improve accessibility for all and reduce the need for individual accommodations.
So if you have any questions, you're welcome to contact us by email. I know that there'll also be a question and answer period following the presentation, but included our contact details here. And that is our presentation.